Today, we're breaking down an absolutely critical emergency protocol, how to manage postpartum hemorrhage. This is all about taking fast, decisive, and structured action when every single second counts. To really understand what's at stake here, let's just start with this one number, 41%. In Pakistan, that's how many direct maternal deaths are caused by obstetric hemorrhage. It is the #1 cause, which is exactly why knowing this protocol inside and out is non-negotiable. So, what are we actually dealing with? Well, primary postpartum hemorrhage, or PPH, is clinically defined as losing more than 500 milliliters of blood within 24 hours of giving birth. But look, the most important thing on this slide is the urgency. Most deaths, they happen within just 2 hours of delivery. We call that the golden window for a reason. It's the window for survival. Okay, so here's our game plan for mastering this. We're going to cover why it's such a threat, what the trigger for action is, how to diagnose the cause with the 4Ts, what to do first with the motive bundle, what happens when the bleeding won't stop, and finally, we'll put it all together in your PPH action flow. First things first, we have to understand the stakes. This is not a wait-and-see kind of situation. Really getting a feel for the speed and severity of PPH, that's step 1 to managing it well. And that brings us to the big question, right? We know what PPH is, we know why it's so incredibly dangerous. But what's the signal? When, exactly, do you pull the trigger and officially declare an emergency? The answer is all about early, and I can't stress this enough, accurate detection. This isn't about making a guess, it's about precise measurement. This is the starting block for the whole response. And this right here highlights a massive, all too common mistake, just eyeballing it. Visual estimation is notoriously bad. You often underestimate the blood loss by half. That's why you have to use a calibrated drape, just like the one you see here. The standard roll, you act at the 500 ml mark. But, and this is important, notice the compromised protocol. If your patient has a condition like severe anemia, you don't wait. You act at 300 ml. So, the alarm has been raised. You've hit the trigger volume. Your next move, which you're doing at the same time as your first response, is a super fast diagnosis. You've got to figure out why the bleeding is happening to treat it correctly. And this is your diagnostic toolkit in a nutshell, the 4 Ts. Think of it like a rapid-fire mental checklist. First is tone. Is the uterus atonic? Is it failing to contract? This is the big one, the culprit in about 69% of cases. Next, tissue. Any retained placental bits? Then you have trauma, lacerations, tears. And finally, thrombin. Is there a clotting problem? Your exam is just zeroed in on figuring out which of these it is. Now, as soon as you have a likely cause, or even while you're still confirming it, you have to launch the first-line response. This isn't just a list of ideas. It's a proven, evidence-based sequence of actions called the motive bundle. Let's break this down. It all starts with M for massage, sustained uterine massage to physically get it to contract. Immediately, you've got O for oxytoxics, like oxytocin, to chemically force that contraction. Then T for tranexamic acid, or TXA, which helps stop clots from breaking down. At the same time, I for IV fluids to fight off shock. And finally, E for examination and escalation. That's where you confirm the cause with the 4 Ts and get ready to escalate if things aren't improving. But what if you've done the entire motive bundle and the bleeding just keeps going? That's called refractory PPH, and it means you have to escalate to the next level of care, like right now, no delay. In that case, you have 2 major interventions. On the left, you see the uterine balloon tamponade, or UBT. Its whole job is to apply pressure from the inside. You inflate a balloon inside the uterus to physically press on the bleeding vessels. On the right is the non-pneumatic anti-shock garment, or NASG. This does the opposite. It applies pressure from the outside, squeezing the lower body to reverse shock and buy you precious time. If there's one thing to burn into your memory, it's this. Rapid action saves lives. Do not delay intervention. Every single minute you hesitate is a minute that dramatically increases the risk of a fatal outcome. Okay, let's put it all together now. We're going to build a clear mental model. This is your complete PPH action flow, from the very first sign of trouble all the way to escalation. And here it is, the whole sequence. It kicks off with the trigger, that accurately measured blood loss. That immediately leads to diagnosis using your 4 Ts. Then you launch the first-line response, which is the motive bundle. And if that's not enough, you escalate to refractory management with a UBT or NASGAR. And remember, all of this has to happen inside that critical 2-hour golden window. Let's leave it with this final, powerful thought. In obstetric hemorrhage, hesitation is fatal. Diagnose early, act sequentially, escalate rapidly. At the end of the day, it's not just about knowing the steps. It's about how fast and how decisively you can execute them when a life is truly on the line.